Hello everyone. Today we are going to discuss pharmacology of antifungal drugs, or we can call it as a antimycotic drugs. This point comes under 6th semester pharmacology. Myself, Dinesh Dangar. Before commencing the antifungal agents, we should be aware about the types of fungi or the fungi kingdom. There are major 5 phyla are there. First, that is phylum Zygomycota. That is what the bread molds. Generally, we have seen these kinds of molds on bread. Next one, that is Rhizops, black bread mold. Second, that is phylum Omycota. That is the water molds, water mold, potato blight, and mildew. Third, phylum Escomycota. It is the sake fungi, can be seen on yeast, morels, and truffles. Fourth, that is phylum Basidiomycota. It is the club fungi. It is mushrooms, puffballs, bracket fungi, rust, smuts, and toadstools. Fifth one, that is phylum Mycota. It is the fungi imperfecti. And we can see here in diagram those different types of fungi can be seen on it could be on a bread, it could be on a potato, it could be on yeast, mushroom, bracket fungi, and the fungi imperfecti. So these are the antifungal agents can be used to treat two different conditions. One, superficial fungi infections, and it will be present on superficial layer of skin and the mucous membrane. Second one, that is systemic fungal infections, that is the present in lungs or central nervous system. In both the cases, our approach will be different in cases of their treatment. Fungi causing mycosis live as commensally or are present in the environment. Earlier, superficial infections were uncommon and systemic rather than rare. Recently, there is increase in local as well as systemic fungal infections, and there might be a n number of reasons behind the development of local and systemic fungal infections. And the reasons could be the opportunistic infections. What is this opportunistic infections? It could be developed due to the immunosuppression, and then immunosuppression could be driven by cancer chemotherapy, acquired immunodeficiency syndrome, and corticosteroid overuse, as well as it could be driven by indiscriminate use of broad spectrum antibiotics. The way antibiotics are prescribed, it may lead to develop systemic fungal infection as well as local infections. Fungal infections. Here we can see the superficial and the deep mucosa. In cases of superficial, we can see it on skin, hair, nails, and mucous membrane. In diagram, we can see where exactly it is located. In skin, just near to the thumb, and even it can be present inside the scalp of hair or those rootlets of hairs as well as in nails. In the cases of deep, they may involve those tissues, that is muscles and the connective tissues, as well as it may penetrate the organs. While coming to the classification for antifungal agents, first category, that is antibiotics, and they are the major one. A, that is polyene antibiotics like amphotericin B. Next is nystatin, hyamycin, natamycin, that is pimarisine. B, that is heterocyclic benzofurans, that is griseofulvin. This classification is based on the chemical moiety. Second, that is antimetabolites, that is flucytosine, that is 5-FC. Third category, that is azoles. Into that first, imidazoles. In the cases of topical, we can have clotrimazole, iconazole, miconazole, oxyconazole. In cases of systemic infections, we can use ketoconazole. In cases of systemic, certain triazoles are used, that is fluconazole, itraconazole, and voriconazole. Fourth, that is alanine derivatives, that is terbinafine. Fifth, that is other topical agents that can be used to treat superior or superficial infections, that is tolnaptate, andecyclinic acid, benzoic acid, quinoidochlor, cyclopirox, olamine, butanafine, and sodium thiosulfate. Okay, what are the targets for the antifungal therapy? Here we have a molecule, that is fungi, right? It has got cell membrane, next is nucleus and cell wall. As we are aware that human cells are different than those parasites, or we can say that fungal or microbial or bacterial cell, because they may have a cell membrane as well as cell wall. In cases of human being, it has cell membrane. There will not be a presence of cell wall. So, what will be the target sites for our antifungal agents? First, that is cell membrane. Generally, fungi uses the ergosterol instead of cholesterol. In cases of human being, cholesterol will be present. Second site, that is DNA. Some compounds may be selectively activated by fungi, which could arrest the DNA synthesis in fungi. Next is cell wall. Unlike mammalian cells, fungi will have a cell wall, as I earlier stated. Okay, what is the structure of cell wall in cases of fungi? Here we can see those nanoproteins. Next is chitin, ergosterol, beta-1,3 glucan synthase. In case here, cell membrane may have a major role of ergosterol. In cases of human being, there will be a presence of cholesterol. Here, ergosterol will be present, and this is the major target site in the cases of superficial infections. First category, that is polyene antibiotics. First, that is amphotericin B. This is the fermentation or fermented product of Streptomyces nodosus. It has got high affinity for ergosterol, which is present in fungal cell membrane. Hydrophilic polyhydroxyl chain along one side and a lipophilic polyene hydrocarbon chain on the other side in amphotericin can be seen, and this both the sides, they bind the sterols in fungal cell membrane, and they may have a high affinity for ergosterol, which is present in fungal cell membrane, and affinity is less for host cell membrane, although they closely resembles to it, so it won't invade normal healthy cells of human body. It creates the transmembrane channel and electrolyte leakage in cases of ergosterol or fungal molecule. Bacteria lack sterols, so they are insensitive to polyenes. So polyenes are strictly restricted for fungal infections only. While coming to their antifungal spectrum, they are the most toxic antifungal agents. They are fungicide at high and static at lower concentration. Effective against Candida albicans, Histoplasma capsulatum, and Cryptococcus with Aspergillus infection. Pharmacokinetic parameter. Generally, they are insoluble in water, as well as they are poorly absorbed from gastrointestinal tract. So it will be used in form of creams. It cannot even cross blood-brain barrier. They are highly bound to the plasma proteins, and generally it takes 2 months for the complete clearance of drug from the body. In cases of systemic, it can be given as intravenous infusion. For fungal meningitis, it can be given intrathecally, that is to directly into the brain. It is immunostimulant actions also given in immunocompromised patients for fungal infections. Uses of choline antibiotics. They are broad spectrum antifungal agents and useful for candida that causes oral, vaginal, and cutaneous candidiasis. In cases of cryptococcus, histoplasma, aspergillosis, and they are also effective for leishmaniasis. Adverse drug reactions of choline antibiotics, that is amphotericin B. Certain acute reactions can be seen with choline antibiotics. It may produce chills, nausea, vomiting, pain, fever, itches, dyspnea, and others. Generally, corticosteroids are administered along with the drug to reduce these kinds of adverse drug reactions. It may produce thrombophlebitis, bone marrow depression, that is reversible anemia can be caused. On intrathecal injection, it may produce headache, vomiting, and certain nerve paralysis. Even renal toxicity leading to the azotemia, decreased glomerular filtration rate, acidosis, hypokalemia, and inability to concentrate urine can be seen. Now coming to the newer amphotericin B. They are developed to overcome side effects, to improve the tolerability of drug, to get the drug at the site of action, and to reduce the toxicity. As we know that choline antibiotics, older one may have a higher side effects and adverse drug reactions. So with this new amphotericin B, these are all points can be resolved. And these formulations are amphotericin B lipid complex, amphotericin B colloidal dispersion, liposomal amphotericin B, and only drawbacks of this formulation is less efficacy as compared to the older formulations. Drug interactions. It may show drug infections with flucytosine. It may produce synergistic action with flucytosine. Rifampicin and minocycline, even these both can potentiate the effects of amphotericin B. Next is vancomycin and aminoglycosides. They both increases the risk of nephrotoxicity. Next is preparation and doses. Generally 50 to 100 milligram 4 times a day orally will be given. In cases of ear infection, 3% ear drops can be used. Cases of systemic, 50 milligram vial, that is 1 vial diluted in 500 ml of 5% glucose, and initially 1 milligram test dose, that is followed by the infusion for 4 to 8 hours are used. Nystatin. It is similar to amphotericin B but more toxic than the amphotericin B. It is used only for superficial candidiasis of skin, mouth, vagina, and the intestine. Generally, it is used in forms of ointments, oral tablets, and the suppositories. They are available as tablets and the ointments. Also available the vaginal tablets. Orally, they are not absorbed but can be used in monilial diarrhea. Other pollens like hamycin, they are water soluble. It can be absorbed from the gastrointestinal, but it is not reliable. It is not used for systemic fungal infections, and it is usually topically for aspergillus, candida, monilial trichomonas, and vaginalis infection. Next is natamycin. They are the broad spectrum antibiotic and used tropically for keratitis, monilial infections, and trichomonas vaginalis. Next category, that is imidazoles and the triazoles. First into that is azole antifungal agents. Into first, that is imidazoles. Topically used are clotrimazole, iconazole, and miconazole. Whereas in the cases of systemic, we can use ketoconazole. Even triazoles are used, that is fluconazole, itraconazole, and the voriconazole. Here, We need to remember that among imidazoles, only ketoconazole is systemic, others three are topically used. Here, remember one thing, only ketoconazole is systemically preferred. Others all are topically used. In cases of triazoles, they are used systemically as well as largely replacing ketoconazoles. While coming to the mechanism of action, that is for azoles, as we can see that the major component in the cases of fungi, that is ergosterol, and the mechanism of action for those azole is to interrupt the production of ergosterol. The sequence is described here. In fungi, the cytochrome P450 enzyme, that is lanosterol 14 alpha demethylase, it is responsible for the conversion of lanosterol to the ergosterol, that is the final step. Here, azoles bind to those lanosterol 14 alpha demethylase, inhibiting the production of ergosterol. If there won't be a formation of ergosterol, the fungal cell cannot survive. Some cross-reactivity is even seen with mammalians, that is cytochrome P450 enzymes, leading to the drug interactions and impairment of steroidogenesis that can be seen with ketoconazole and the ketoconazole. While coming to their spectrum of activity, yeast and molds can be treated with it. They may have a poor absorption limits, its role for severe infections, and generally used in cases of mucosal infections only, that is dermatophytosis. Pharmacokinetics. The variable oral absorption can be seen, and it generally depends on the pH, right? Often given with the cola or fruit juice. The half-life is 7 to 10 hours, and their protein binding capacity is more than 99%. And hepatic, bile, and kidney amylation can be seen with elimination phase. Adverse effects that can be seen with ketoconazole: nausea and vomiting, and it may persist with the higher doses, that is more than 800 milligram per day. It produces hepatotoxicity, that is 2 to 8% cases, and it increases in transaminases, and the may produces hepatitis. Dose-related inhibition of cytochrome P450 responsible for testosterone synthesis and may lead to the gynecomastia, oligosperma, and decreased libido. Gynecomastia, that is a kind of condition where in male breast formation can be seen, whereas in the cases of decreased libido, sexual intercourse may be retarded by the person. Those related to the inhibition of cytochrome P450, that is responsible for adrenal cortisol synthesis. Drug interactions with ketoconazole. They are the potent inhibitors of cytochrome P450-3A4. And this, as we know that human liver may have more than 400 types of cytochrome P450. Here, rifampin and phenytoin decreases the levels of the ketoconazole. Ketoconazole increases the cyclosporin, warfarin, estamizole, corticosteroids, and theophylline levels. Many of these drugs interactions are severe and life-threatening. Drugs that increases the gastric pH will decreases the blood levels of the ketoconazole, that is antacids, omeprazole, and H2 receptor blockers. General doses, that is for in cases of serious infections, 800 milligram per day post-orally, and in other cases of other 200 to 400 milligram per day post-oral. Next drug, that is fluconazole. It is water soluble, having wider range of activity than the ketoconazole. Good activity against Candida albicans and the Cryptococcus neoformans can be seen. Non-albicans Candida species more likely to exhibit primary resistance. Here we can see that from the always resistant to the sometime resistant. They are available as both intravenous as well as in cases of post-oral administration, and their viability will be more than 90%. That plasma half-life, that is T half-life, is according generally 24 hours, and then protein binding capacity is less than 12%. Volume of distribution will be 0.85 liter per kg, and they are widely distributed throughout the body. More than 90% excreted unchanged through the kidney. While coming to their dosing, in cases of mucosal candidiasis, 100 to 200 milligram per day. In cases of systemic fungal infections, that is 400 to 800 milligram are used. In cases of maintenance for the cryptococcal meningitis, generally 400 milligram is used. Adverse drug reactions. Nausea and vomiting with rashes can be seen. It is more likely with high doses and in patients of AIDS, and asymptomatic increases in LFTs, that is 7% chances. In cases of drug interaction, it may increases the phenytoin, cyclosporin, rifabutin, warfarin, and zidovudine concentrations into the body, may leading to the toxicity of it. Rifampin, that is reduced fluconazole level, that is to half, and even through the fluocytosine is not a major substrate. Next drug, that is itraconazole. The basic features of itraconazole are they are newer orally active triazoles, and they may have a broader spectrum than the ketoconazole and the fluconazole. It includes the molds like aspergillus. They are basically fungistatic actions but very effective in cases of immunocompromised patients like AIDS. Next is steroid hormone synthesis, that is inhibition is absent and no serious hepatotoxicity can be observed with itraconazole as compared to the ketoconazole and the fluconazole, where hepatitis was produced. Here we can compare ketoconazole, fluconazole and the itraconazole. Local azoles. They are very popularly local azoles are clotrimazole, iconazole and the miconazole, and can be used for the trypnoea, ringworm, athlete's foot, otomycosis, oral cutaneous and vaginal candidiasis. Their mechanism of action is same as that of ketoconazole. Aldosterone inhibition by inhibiting cytochrome P450. Clotrimazole is flavored in vaginitis because of long-lasting residual effect and once daily dosing. Heterocyclic benzopyrenols like griseofulvin can be used. It is used for superficial fungal infections by dermatophytes. They are basically derived from the Penicillium griseofulvum, but no bacterial effect can be seen. It is effective against most dermatophytes but not against Candida, causing deep mycosis. They are the dermatophytes, they are actively concentrate it and accounts for the selective toxicity against them, and they are taken up by the newly formed keratin. While coming to their mechanism of action of griseofulvin, it interferes with the mitosis of the fungal cell and results into the multinucleated and stunted fungal hyphae. And this, in most fungi, hyphae are the main mode of vegetative growth and are collectively called a mycelium yeast or unicellular fungi that do not grow as hyphae. Abnormal metaphase configurations that may leading to the failure of daughter nuclei to fall apart, and there will not be a further cell division of it. So there will be a disorientation of polymerized microtubules leading to the fungal cell death. The pharmacokinetic parameters, they are given orally and generally it includes the metabolic absorption of fats. Absorption depends on the particle sizes. In cases of cream, duration of treatment depends upon the tissue turnover, that is 3 to 6 weeks for skin and hair, 3 to 6 months for the nails. While coming to their doses, generally 125 to 250 milligram 4 times daily can be used. Adverse drug reactions like GIT upsets, CNS symptoms, hepatotoxicity, leukopenia, photosensitivity, and allergy can be seen. Generally, they are the microsomal enzyme inducers. So it increases the activity of liver. It causes decrease in activity of anticoagulants and causes intolerance to alcohol. Flucytosine. They are the fluorinated pyrimidine that is related to the fluorouracil. They are restricted again up to the spectrum of activity. They are acquired resistance due to the result of monotherapy, and it might be because of decreased uptake, that is permease activity, and altered 5-fluorouracil metabolism. While coming to the kinetic parameter, they are orally absorbed and widely distributed even in cerebrospinal fluid, and they are excreted in urine. It is converted in fungal cells to 5-fluorouracil, which is anti-metabolite and which we have already studied during anti-cancer agent. In cases of monotherapy, it is not used. Generally, it can be used with the combination with amphotericin B and or fluconazole. In cases of candidiasis, cryptococcosis, and aspergillosis, that doses may be variable. In the cases of vaginal candidiasis, dermatophytosis, and the onychomycosis, their adverse reactions they may produce mild, depressions, that is bipolar or multipolar depression, and alopecia, that is loss of hair, can be seen. Next is terbinafine. It belongs to the newer allylamine class of antifungals. They are given both orally as well as locally. They are lipophilic, so widely distributed throughout the body, and fungicidal in contrast to the azoles, because azoles are basically fungostatics. They act by non-competitive inhibition of squalene epoxidase, which is the early step enzyme which is required in the synthesis of ergosterol. So here there will be accumulation of squalene in fungal cells and may produce sedal effects. They are used for dermatophytes and the candida infections. Their dose may be 250 milligram once in a day for 2 to 6 weeks, and even it can be used in form of ointments locally 1%. Adverse reactions: GI upset, hepatic dysfunction, races, and taste disturbances can be seen. Their preparation could be in 1% cream, that is 125 to 250 milligram tablets, as well as tinea paddies, that is for 250 milligram once in a day for 2 to 6 weeks. So this is all about antifungal agents. Thank you.